It's a really pleasure being here. I had the opportunity to come and teach alongside my brother and learn so much from these conferences for many, many years. And it may feel like you're hearing the same person say somewhat the same thing in a row, but it is indeed a different person. But the topic that I'm going to talk about is shared decision making, and it's a model or it's a practice of patient care. You'll hear a lot of kind of overlapping themes between this and the following presentation on ethics. There's really a foundation to what we believe is optimal healthcare, what really is the foundation of a healthcare system and the relationship that we have with our patients that really leads to optimization of healthcare. It's not based on finances, it's not based on technology, it's based on your and your patients' interactions, your beliefs, and the things that you hold true to the practice of medicine. And so my talk is called Shared Decision Making. It's an integral part of patient-centered care. And as you've already heard, Sir William Osler said, the good physician treats the disease. The great physician treats the patient that has the disease. The great physician or nurse understands the patient and then adapts what they do based on that understanding. And William Mayo, Jay has already referenced the primary value of the Mayo Clinic, but William Mayo said, and this was his actual quote, the best interest of the patient is the only interest to be considered. And then he went on to say, and in order that the sick may have the benefit of advancing knowledge, a union of forces is necessary. What you're experiencing today is that a union of forces, of physicians, young, more experienced, of nurses, of pharmacists, of occupational therapists, of people in all aspects of healthcare coming together to join for the benefit of the advanced knowledge for our patients. So there is a concept of informed consent, and this is not shared decision making. How many of you practice informed consent? Mostly this is done in the setting of procedures, where a decision is sort of being made to proceed with usually a procedure, an intervention, and it's a unidirectional kind of process where we're sharing information about what to expect, what the risks and benefits might be, what the plan might be, and then we're basically providing, I gotta get these things right, we're providing to the patient the opportunity to either accept or reject that proposal. I'd like to take your appendix out, this is how it's going to happen, here are the risks, and then sign on the dotted line if you'd like to go ahead and do that. And that was an important process that was developed, and we often document that interaction. And this origin of this process of informed consent was based in laws related to battery, where we're not doing unwanted bodily harm to our patients. We're not doing things to them that they would not want. And this is very important. It protects our patients and it protects us, but it is not the same thing as shared decision making. So what is shared decision making? And I just want you to know that you'll get copies of all of these slides. They'll be available for your reference. Within my presentation, there are some QR codes that will take you to some deeper references that you can use. But what these things are trying to do, and what I'm trying to do here, is to codify in a way something that you may already do or may already do some aspects of, but to really help understand how this is done, and that way to embed it into your everyday practice, but then also, just as importantly, propagate it to others. So learning how to do it yourself and then propagate it to others through modeling and teaching. So I just put that plug in, so I hope you pay attention maybe as to This is more than just information sharing, but it's a building exercise for your practice and hopefully one that will propagate to others. So what is shared decision making? Well, it's involving the patient in medical decision making to the degree that they desire. What do I say? That sounds okay. No, that's really not it. That's an incomplete decision. So we're going to kind of tuck that aside. Not just to the degree that they decide. There's actually a lot more that goes on with shared decision making. So the elements for shared decision making to really occur is a meeting of the minds, this picture. It's the physician and the patient or their caregivers. A meeting of the minds where more than one reasonable option exists. So I don't practice shared decision making when it's very clear that, say, putting your dislocated shoulder back in its joint is optimal care. I don't want to find out kind of what the preferences are of the patient. I don't need to spend time understanding their context when their shoulder is dislocated. They want it back in, I want it back in. I might talk about different techniques. And the same goes for things like vaccinations. We believe vaccinations are important. We make recommendations. We don't force our patients to get them, but I don't use this same process necessarily unless we kind of run into conflict. But I tend to approach certain things where there's a clear there's often choices, but there's sometimes very clear best options for somebody. So first of all, there has to be more than one reasonable option existing, which then it has this notion of decisional conflict or some sort of problem. And then, in order for shared decision making to occur, the patient actually has to have a reasonable understanding of the best scientific evidence. And you might think, well, how in the world is that possible? My patients don't have much medical knowledge at all, let alone just general basic literacy. So how can I do that? Well, this is where we bring it to their level, and I'll explain how you might approach that. But this is not meant to be aspirational, where they understand all the best evidence, but to the best of their ability, they can incorporate some of what you know into how they're going to make their decision. And then the healthcare provider, and this is really key, this doesn't have to take a long time. We can ask some very clear, targeted questions. We can pay very close attention to the context of what's going on around us. And we can try to have an understanding of what their values, their goals, their beliefs, and their preferences are. And we incorporate that into our recommendations as we're having this back and forth. So we start to realize that, you know what, some of what I think might be optimal for them clearly wouldn't be. So I'm going to start to not maybe focus on those recommendations, and I'm going to focus on some other choices because I'm understanding now in a better sense what's likely best for them. And so there's these Venn diagrams, and you can sort of look at it and say, well, if we combine what the patient preferences are, the context and the research evidence, and we find right here this overlap of all, and that's where shared decision-making takes place. And that's a nice picture, but I'm not sure how helpful that really is. So shared decision-making there's a lot of words here, but I try to highlight the key ones. It's collaborative. We collaborate with our patients to do it. And then we make important decisions, not, all decisions have a level of importance, but some of them are not quite as important. What color Band-Aid do you want on your cut? That's not that important. I do that a lot with my patients because they're kids and they like, they like little characters, or they may just want pink. But those are not really super important. And so then there are also, as I mentioned, more than one reasonable option. And we incorporate evidence and effective communication to really help individualize the patient's priorities, preferences. And there's ethical underpinnings to this, why we do this at patient-centered care. And really one of the key ones is the idea of self-determination, or we use the fancy term autonomy. That is, as human beings, we have autonomy. But in reality, I would say that there's a relational autonomy. That patients, yes, they do indeed have autonomy, but it is not really fully actualized without our input to help them know what might be best. I might say that I have complete autonomy over my body and all the decisions, but I may have absolutely no clue what the best medical choices might be to help optimize my care. So it really is a relational autonomy, and we are dependent on each other. And then there's also this concept of agency or decision making. And that's part of autonomy is the agency to make a decision. Now, sometimes we have to do this on behalf of others. We do this on behalf of our loved ones who no longer can speak for themselves. And that's through understanding their wishes. And so, but agency does require knowledge. We may think that we can make great decisions, and our children are wonderful examples of this. They want agency, they want to make decisions, but they have absolutely no clue what the results of those decisions will be, and death is usually high on the list. So shared decision making really helps us confer agency to the person who ought to be able to make the decision by providing key information and then supporting them in the decision-making process. Just like our children, we help support them to pick the right kind of clothes to wear for the weather. Here it's not as hard as in Minnesota, where flip-flops and shorts may not work very well in February. But we support their decision-making process to get them to where they need to be. Now there is data on this, and this is a study where they looked in a decisional psychology journal at the role of physicians' recommendations on medical treatment decisions. And really what they were looking at for is, can we as physicians or providers guide people in the wrong direction? And to summarize this study, what they did is that they asked patients to make a decision in the absence of any recommendation from a physician. And they looked at the patients who, with the information provided, made what they would consider the right choice, the choice that would optimize their health. And then they got us involved, and we started to mess things up a little bit. And so when they took the patients who would 100% of the time actually choose the right thing, and then in comes the physician who starts making some recommendations, often sometimes away from optimal health care, you can see what happens. They went from 100% down to those getting treatment, 81% of the time chose optimal instead of 100%, and not getting treatment 92% of the time. So we actually pulled people away with our recommendations from making the right choices. That means we have influence, and I think we all knew that. We all really did know that. This is not revolutionary, but it shows with data that we, if we're not careful, can actually lead people away from optimal health care, things that they would typically prefer. Okay, so beyond the ethics, and this gets back to a little bit of what my brother was talking about with some of what he was saying, there's also other good reasons to practice shared decision-making. The efficacy and experience, as well as healthcare utilization, are improved when we practice medicine this way. Patients who participate in decisions on their care are more likely to adhere to a plan. And that's what we want. We spend this time trying to help figure out an optimal plan, and it's great if they actually adhere to it. And when they feel more involved in their own care, they have a better experience, regardless of the outcome. Meaning, if we are treating them for a condition where the treatment isn't 100% effective, they may still suffer from symptoms of that condition, but it may be lessened to some degree, or they may still end up succumbing to that condition. They feel better about the care they've received and the outcomes. And that's just that's something that we all want. It also can help decrease overutilization of resources. Because we often feel like what our patients want is more of something. They want more tests, they want more interventions, but in reality, we overestimate what they may want. And an informed patient often chooses less invasive or aggressive or expensive approaches. And that's not simply based on the finances of it, but it's based on their understanding of the risk, cost, benefits, and how it applies to them. So it can really help with overutilization. And in a really healthcare, financial strapped setting, this can make a big difference. And it certainly can make a big difference where we are also a healthcare strapped financial situation in the United States, but just at a different magnitude and level. Knowledge transfer is very important, as I've mentioned. And how do we reasonably accomplish this? How do I take the years and years of my schooling and knowledge and the Krebs cycle or different pharmacologic concepts and transfer? Well, it's not, the goal isn't that. It's not for them to understand electron transport chains, which are fascinating, and I might love that, but it's probably not critical. But it is really important to help them understand certain aspects of medicine. And so we are all very time constrained. We rarely have more time than we need to spend with patients. So we need to develop things to help us speed up that interaction. And decision aids are one way we can do this. And I'm going to show you some examples of this that have been developed at the Mayo Clinic and are being developed around, that you can just do a search, say decision aid for statin use or decision aid for head injury. And this is a way that you can make your sharing of knowledge or knowledge transfer more efficient. So I'm going to give you an example. This is a 3-year-old female brought in by parents after falling off a bike onto their head, no helmet. And she's had no loss of consciousness, but she's vomited several times. And the injury occurred 3 hours ago, and the parents are looking to you to help guide them. But she looks well, she's a normal exam, but the parents are very concerned that she might have a serious brain injury. They've heard of other children who've had injuries to their head who have died, and they know of this CT scan that they could potentially go to, and they really feel like they need this CT scan, and they're looking to you to help them make a decision. Well, we have lots of data on minor head injury in children and predictors that can make them higher or lower risk for needing a neurosurgical intervention. For needing a pediatric neurosurgeon, you're going to hear from one of those this conference. Do we need Teddy Totema or not to help us out? And this is a decision aid that we developed at Mayo, which uses pictures, pictorial representations of things, and contains a lot of information in an area. This may not be ideally suited for your setting. You may want to change some of the words, you may want to change some of the graphics, or you may just want to use it as is. And it separates out the concepts of brain injuries that we can see on a CT scan, which are on the right, and things like concussions, which are brain injuries that we can't see on a CT scan. And then it helps us convey risk. And in this case, based on certain factors of this child, we can tell these parents that your child's risk is less than or about 1 in 100 that they'll have blood in or around their brain. And now they can see this picture. And their level of concern was like, my child is this one. And it may not change it at all, but they might see their child as this one, as one of these, especially after your knowledge and sharing and your reassurance. And they may now understand that CT scan probably isn't necessary. But then we also can share with them the data between what's the difference between getting a CT scan or observation and what the risks might be. And this is a piece of paper you can hand, assuming that your patients are literate and can go over this before you even talk with them. That can be done by a nurse in triage. And you can talk about things like observation and what to bring them back for, and reinforcements. And then this is another part sometimes of a shared decision, of a decision aid, is what are kind of the pros and cons between different things. And this was developed by asking patients what's important to them. And some of the things that were important to them was radiation exposure, or my child needs sedation, or how much does it cost. And you don't have to spend time going through every one of these. If cost is the most important thing, you can focus on that. And yes, a CT scan costs more than observation. Or how long will this take? And so again, these are just one example of decision aids. And there are many of these for a variety of different conditions, and they continue to be developed because it's part of the practice of bringing shared decision making into all of our busy lives and practices. And this is about knowledge transfer. And this one in particular right here, this page of this is about finding out what are some of the key important things to the individual, in this case the parents or the decision makers. Another example of shared decision making may occur in a different setting. And this is actually a friend of mine who had metastatic testicular cancer, third recurrence, and now basically just refractory is terminal. And he put together his goals based on his mental status being intact. He had a large right-sided pleural effusion, was on home oxygen at night, really had no appetite. He knew he was in the terminal stages of his disease. But interestingly, and confounding things, was his wife was pregnant at 22 weeks, and so how long was he going to make it? How long might he want to survive? And so he put together what was called a pulse. How many of you guys have heard of a pulse? You have those? We have things like DNR, DNI, do not resuscitate, do not intubate. This goes a little bit further. This is something that is done, and it's done between a healthcare provider and the patient. And what it does is it helps outline what the orders for life-sustaining treatment might be for patients who have, most of the time, terminal illnesses, but not always. And it takes into account their diagnosis, their prognosis, and then the treatment options that would exist, the pros and cons. And it incorporates the values, beliefs, and goals of care for the patient. And I'll show you what this looks like in a form. But it's done by taking all the information of their situation. So this is not something that you just do at a quick one-time visit with a patient you've never met before. Although you could, but it'll take a little bit of time to get to understand what their situation is. But this is often done in the primary care setting after you've gotten to know somebody, and you work together to make decisions and then fill out a form that they can keep with them for when they need to seek care at places or with people that don't know them as well as you do, often in an emergency setting. And this is an example of a providing orders for life-sustaining treatment form. There's information about who it's about, and then obviously it has things like CPR, DNR, DNI, but then there's goals of treatment. Like they really want to focus on comfort care, or maybe only provide life-sustaining treatment. You can check off any one of these things. It gives contact information. It talks about, hey, what I want antibiotics, what I want fluids, what I would maybe want to be intubated temporarily if it meant something. So it gives additional information. Talks about things like nutrition and other goals, tube feeds or not, and it really can help outline. And this is another way of practicing shared decision making, pulling together the desires and the wishes of the patient. And ideally, in an ideal setting, this would be incorporated into an electronic medical record where wherever this person showed up, you'd be able to pull it up. But ideal and reality don't always line up. So copies of this, pictures of it on their phone that a provider or care providers that can bring and show to the healthcare provider that is seeing them that this is what they want. This is what they said they wanted, even though right now they can't speak for themselves. All right, I'm going to be kind of pulling this all together and just providing a little bit of an extra kind of spin on it for you as we wrap up here.
There's people who study this, and Hargraves is the name of one of the authors who've published on this. And there's a QR code and this is available to anybody who wants it. You shouldn't have to have access on a publication that came out in 2019 that really tries to kind of further our understanding of shared decision making in healthcare. And they kind of try to organize this in a way that says, what is the problem in the care? If there's no problem, we both are likely to be on the line and there's no real need. We're just going to go ahead and solve that laceration and get it taken care of. What should we be talking about together in this situation if there is a problem? What form of shared decision making should we use? Now, forms, now this is getting complicated. How am I supposed to remember different forms of shared decision making? Well, it's easy when I give you some examples, you'll understand it. It's all kind of a similar flow and pattern. Okay, so first of all, there's kind of uncertain outcomes. This is should I CT my child's head or should I not CT my child's head after they've injured their head? And we go through kind of a weighing of the different options and making a decision together collaboratively based on information. Another time where we use shared decision making is when there may be some interpersonal conflict. There may be different positions. My brother talked a little bit about this. The positions of we both really want what's optimal for your child's health, but we have different positions on what we think or how we believe we can achieve that through vaccination or through avoidance of vaccination. And here is where we use a negotiation sort of approach to shared decision making rather than a weighing of the pros and cons. And then there's also when there's trouble or a confused situation. The situation is a little bit murky, we're not sure, and we can use a problem-solving approach to shared decision making. And I'll give you a good example of this, or at least I think it's a good example because I made it up. But a good example of this, just to help anchor you into this idea of problem solving. And then lastly, you can use shared decision making when there's sort of an existential fracture or transition. And you might say, what in the world? I'll give you an example of this too, but this can be done to help sort of bring meaning to a situation or help somebody understand identity issues and then develop insight into a problematic situation. So here we go. These are the situations. So selection options, we've already covered this. CT or no CT. What type of statin or blood pressure medication would be optimal for me to use? There are decision-making aids to do that. And then somebody makes a choice based on it. How about negotiating conflict? I've run into this in the emergency department. We have an unvaccinated child. The parents have chosen not to vaccinate their child at all, but they come in with a tetanus-prone wound. This is supposed to be a deep wound in the foot, rusty. We know they're at high risk for tetanus, but they're unvaccinated. What do? Well, we have a problem because I'm worried that that their child is at risk for something, and they've decided not to employ vaccination. Well, we can have a little bit of a negotiation, and I have a way to protect their child, which is an antibody called tetanus immune globulin. And they may be open to that. And then we might be able to open the door to helping them develop their own immunity. But at least in this case, we negotiate, we might come to a conclusion that we'll give your child tetanus immune globulin to protect them from this exposure, and hopefully they won't die from tetanus. And then we can talk more in a different situation about doing your active immunization. How about problem solving? We've got a patient who's a diabetic who, when they were with mom, their blood sugars are great. They do wonderful. But when they stay with dad, because they live in separate homes, they get hypoglycemic all the time. Because dad just gives the insulin, but he doesn't monitor the diet. And she keeps getting sick. Well, do we change optimal diabetes management because dad can't get his act together for both households? Or maybe we keep it optimal at mom's household and we accept the fact that maybe only long-acting insulin and not short-acting insulin is the way to go when she stays at dad's house. We're problem solving, we're figuring something out, we're taking the situations, the preferences, the abilities into consideration rather than just telling the dad, get your act together and start doing it right. Now that's obviously the message, but in the short term, we're understanding that dad, for whatever reason, he's not getting it. So let's change the way we manage here. And then lastly, is meaning or hope. Maybe you have been fighting the cancer for decades now, or your child's cancer, and the goal has always been cure. We've been praying for a cure, we've been believing that we're going to get cured, and that's our only mentality. And there's no other option but cure. But we're realizing that cure is probably not going to happen. And we're struggling, they're struggling with this, and we can say, you know what, there's still something we can do. It's called palliative medicine. It's making the end of life as positive as possible. And we're transitioning from our hope for a cure to our hope for the type of end of life that the patient and the family want. And we're bringing meaning to the situation, and it's another way of using shared decision making. So anytime a patient and a clinician figure out together what to do about a patient's situation, they're doing shared decision making. And I'm going to end with this. Shared decision is not just another thing that we should do, that we add to our list of things to do, but it is really the method of care that we employ in almost every situation, and it is central to the art of medicine. And if you practice this, I guarantee you will find much more meaning, you will find much more satisfaction in your care, and your patients will benefit as well. And I really want to thank you for your time and your attention.